Welcome to topic 9, the endocrine system. So we'll just start with a little brief review of hormones and the normal physiology of the endocrine system. So hormones come from endocrine glands, and endocrine glands are a cell or group of cells or tissue that secrete hormones into the bloodstream. Hormones circulate in the bloodstream and they act only upon specific cells in the body. And those specific cells are cells that have a receptor for that hormone. Those are called their target cells. Hormones operate within feedback systems, which we'll take a look at, and then they get excreted by the kidneys or deactivated by the liver or other cellular mechanisms. Negative feedback is a main mechanism that many hormones are regulated by. And this helps in a lot of homeostatic regulation of things such as blood glucose, blood calcium levels. And here the output shuts off the original stimulus. So in other words, if the original stimulus was low blood glucose, that would cause the release of hormone that would act to raise blood glucose, which would thereby shut off the original stimulus. Many hormones are also regulated by the hypothalamic pituitary target cell feedback system. And this is important for the regulation of hormones from the thyroid gland, the adrenal cortex, as well as the gonads. And here we have the hypothalamus releases hormones that act on the anterior pituitary. Can cause the anterior pituitary to release a hormone, we call this a tropic hormone, that then acts on a target gland to cause the growth and development and secretion of its primary hormone. That hormone has effects on its target cell, and then that hormone negatively feeds back to the anterior pituitary and to the hypothalamus. Okay, so what kind of things cause endocrine dysfunction? A main cause of endocrine dysfunction is hypofunction, and this can be caused due to hyposecretion of a hormone or due to receptor defects. So hyposecretion, we're just not secreting enough hormone, and this could be due to congenital defects. You could be born with a non-functional gland. We could see a decline in function with aging. We could see atrophy of a gland. We could see surgical removal of a gland, such as like removal of the thyroid gland. Destruction of an endocrine gland through like autoimmune disorders, say diabetes, type 1 diabetes mellitus is caused by autoimmune destruction of the pancreas. This could be caused by ischemia or infection. Receptor defects could be caused by a decrease in the number of receptors, or as in the case of like type 2 diabetes mellitus, we could have receptor insensitivity to the hormone. We can also have hyperfunction, and this can be caused by hypersecretion of the hormone, and this can be due to hyperplasia of the tissue. This could be due to benign tumors that secrete too much hormone. It could be due to paraneoplastic syndrome. Remember we talked about this early on. This is where, like, say, a lung cancer secretes a hormone that it's not supposed to, such as ADH or ACTH. This could be due to exogenous hormone administration, such as like Cushing's disease. It can be caused by too much exogenous prednisone. Or maybe you have liver disease. Or the kidney function is impaired, and this could lead to like a longer half-life of hormones. For instance, in liver cirrhosis, we have increased amounts of antidiuretic hormone and aldosterone because the liver is not inactivating those hormones. It could also be due to receptor defects. We can have the presence of antibodies against specific receptors which mimic hormone action. An example of this would be Graves' disease, where we have autoantibodies that are like TSH that act on the thyroid gland that cause too much production of thyroid hormone from the thyroid gland. Okay, we can also classify endocrine disorders on whether they're primary, secondary, or tertiary. Primary disorders are disorders that originate in the target gland responsible for producing the hormone. So let's say you have hyperthyroidism, but it's due to a problem within the thyroid gland itself. The thyroid gland has a tumor and it's producing too much thyroid hormone. Secondary disorder is where that target gland is normal. So let's use the thyroid again. The thyroid is normal, but its function is altered by defective levels of stimulating hormones from the anterior pituitary. So like the anterior pituitary is either secreting too much or too little thyroid stimulating hormone. And then tertiary is where the function of the anterior pituitary and the target gland are normal, but the function is altered by defective levels of releasing hormones from the hypothalamus. So using the thyroid gland as an example, the thyroid gland is normal, the anterior pituitary is normal, but the hypothalamus is secreting, say, too much or too little thyroid releasing hormone, which then is acting on the anterior pituitary to cause it to release too much or too little TSH, which is then acting on the thyroid gland to produce too much or too little thyroid hormone. This slide goes over some of the diagnostic tests that can be used. We can look at blood tests to look at hormone levels. We can look for autoantibodies that might mimic hormones. We can do a 24-hour urine collection to look at hormone levels in the urine. We could give a stimulation test, like if you suspect hypofunction, say, of the adrenal cortex, you could give ACTH, which stimulates the adrenal cortex, and measure cortisol levels to see if there's a response. You could also use suppression tests when hyperfunction is suspected. For instance, you could give glucose to see if growth hormone is suppressed by glucose, or if you have some hyperfunction of the anterior pituitary causing too much growth hormone release. You can also use MRIs for like the hypothalamus pituitary, CT scans looking at adrenal and abdominal tumors or whatever, and ultrasounds are good for thyroid and parathyroid. Okay, for treatment, if you have a hormone deficit, you can treat it with hormone replacement therapy, such as in hypothyroidism, which is pretty common. Many people are treated with Synthroid, a synthetic version of thyroid hormone. Excessive secretion can be treated with some medications to block receptors, block secretion, maybe surgeries, removing the tumor, radiation, irradiating the thyroid gland, for example, in the case of hyperfunction of the thyroid gland. Okay, let's look at the pituitary. The posterior pituitary has a direct neural connection with the hypothalamus. So essentially the posterior pituitary is made up of the axon terminals of axons that originate in the hypothalamus. So here the hypothalamus makes these hormones and they get transported down the axons and they get stored in the posterior pituitary. But the posterior pituitary is primarily neural tissue, it's not glandular, so it doesn't make its own hormones. Rather, those hormones are made in the hypothalamus and transported down and stored in the posterior pituitary. And then those hormones are released in response to depolarization from those hypothalamic neurons. The two hormones of the posterior pituitary are ADH and oxytocin. So ADH, also known as vasopressin, if you remember we talked about this at the beginning of the semester, and this hormone promotes water reabsorption from the kidney collecting ducts. And remember, this causes the insertion of aquaporins. So it allows a part of the nephron that's otherwise impermeable to water to reabsorb water. And thus that would increase blood volume and blood pressure. At very high levels, ADH can also cause vasoconstriction, so that would cause an increase in total peripheral resistance and an increase in blood pressure that way. Oxytocin is responsible for the let down milk reflex in lactating women, and it also promotes uterine contractions during childbirth. This is one hormone that operates under a positive feedback mechanism. For instance, with uterine contractions, contractions of the uterus causes dilation of the cervix. Dilation of the cervix causes more release of oxytocin. And this continues until the size of the cervix goes from about the size of a Cheerio to about the size of a bagel, and then the baby is ready to be delivered. Syndrome of inappropriate ADH secretion is where we have high levels of antidiuretic hormone without the normal stimuli for release. So normal stimuli for release of ADH would be hypoosmolality of the blood, high blood volume. That would, okay, I'm sorry, I just said that exactly backwards. So normal stimulus for ADH release would be hyperosmolality of the blood and low blood volume. Okay, so that would stimulate the release of ADH. And then with ADH, then that would cause water reabsorption, which would normalize the blood osmolality, would dilute the blood, and it would raise the blood volume. But in syndrome of inappropriate ADH secretion, we have ADH levels that are high, but without that stimulus for the release. Now, this is most often caused by ectopic production from a tumor, for instance, a lung tumor. Now, the clinical manifestations are going to be related to too much water retention. So this is going to cause dilution of sodium, so dilutional hyponatremia, as well as hypoosmolality of the blood. This is going to cause an increase in blood volume, and that can result in hypertension and edema. And then the opposite is going to occur in terms of the urine volume. So we have an increase in blood volume and a decrease in urine volume, and that urine volume is going to have high osmolality. Diabetes insipidus is when we have an insufficiency of ADH. And there's two different types based on cause. Neurogenic, also called central diabetes insipidus, is due to an absence or decreased production of ADH by the pituitary. So this could be due to damage to the pituitary or to the hypothalamus, may be caused by surgery, meningitis, a tumor. There is also an inherited genetic form of neurogenic ADH deficiency, diabetes insipidus. Nephrogenic, here the production of ADH is normal, but there's a defect in the kidney tubules that leads to an inadequate response to ADH. There's also a genetic form of this disorder. This can also occur in some chronic kidney disorders and in response to some drug toxicity from drugs such as lithium. With diabetes insipidus, so not to be confused with mellitus, diabetes insipidus is excessive tasteless urine, so it implies that there's no sugar, or diabetes mellitus is excessive but sweet urine. So the manifestations of this are going to be intense thirst, and we can also see that with diabetes mellitus, polyuria, which we can also see with diabetes mellitus, although probably not to this volume, up to 20 liters a day, with a low osmolality. And then because we're losing so much water, the blood becomes concentrated, so we have hypernatremia and dehydration. Okay, so let's look at the hormones of the anterior pituitary. Now the anterior pituitary, actually I'm going to go back to this slide for a second here. The anterior pituitary is glandular, and it makes its own hormones. But these hormones are released in response to releasing and inhibiting hormones from the hypothalamus. Now there is not a direct neural connection here. Instead, there's this portal system where hormones are released into the capillaries of the hypothalamus that travels via this portal system directly to the anterior pituitary, cause the release of, or inhibit the release of hormones from the anterior pituitary. Okay, and these hormones include adrenal corticotropic hormone, or ACTH, which acts on the adrenal gland to cause the release of mineralocorticoids and glucocorticoids. Thyroid stimulating hormone, which acts on the thyroid gland to cause the release of thyroid hormones. Follicle stimulating hormone and luteinizing hormone, which act on the ovaries to cause the release of estrogen and progesterone, and then on the testes to cause the release of testosterone. These are also important, obviously, for fertility. We also have growth hormone, and prolactin. And we'll talk about these in a minute. Okay, all of these hormones are controlled by releasing hormones from the hypothalamus. ACTH, TSH, FSH, and LH are all considered tropic hormones, okay, because they're going to cause growth and secretion from of hormones from their target glands. Okay, hypopituitarism. This ranges from absence of just a selective pituitary hormone to complete failure of all pituitary hormone function, in which case we'd call it pan-hypopituitarism. And this is going to lead to hypofunction of the secondary orders that depend on that tropic stimulus from the anterior pituitary. Causes could be caused by congenital disorders, tissue infarction or infection, head trauma, tumors, or a deficiency of hypothalamic hormones. The signs and symptoms are going to depend on the specific hormones that are affected. For instance, okay, if we have a decreased ACTH, this is going to result in cortisol deficiency. If we have a decreased TSH, this is going to result in thyroid hormone deficiency. If we have a decrease in ADH, this is going to result in diabetes insipidus. If you have decreased FSH and LH, this is going to result in gonadal failure. If we have a decrease in LH, this can also lead to a loss of secondary sex characteristics. A decrease in GH, growth hormone, can lead to low growth in children. And decreased prolactin can lead to no lactation in postpartum women. What I just described, if we have all these things together, then we have pan-hypopituitarism. But once again, like we said, we could have a deficiency of just one of these pituitary hormones, and would manifest in just one of those things. Okay, we can also have hyperpituitarism, and this is most often caused by pituitary adenomas. These are benign tumors of the pituitary. These tumors can be non-functional, or they could be functional. They could secrete hormones. However, if they're secreting hormones, they may be secreting too much of that hormone. So this can result in hypersecretion of the hormone secreted by these cells. Let's say the tumor is of somatotropes. Somatotropes secrete growth hormone. So this would result in hypersecretion of growth hormone. And as the tumor enlarges, though, it can compress on the other cell types and can lead to hyposecretion of other hormones due to that compression. So the clinical manifestations are related to the effect of the mass and the effect of the hormone secretion. So if we have this large tumor here in the pituitary, some of the effect of the mass, it's growing inside a rigid skull. This can cause headaches, seizures, drowsiness, visual defects. If you look where the anterior pituitary is, it can cause problems at the optic chiasm and lead to visual defects. Clinical manifestations are also going to depend on the effect of hormone secretion. So it's going to be dependent on the cell type involved. And this can result in excessive hormone release, like from the cells of the tumor, or decreased hormone release, say, from compression on neighboring cell types. Okay, let's look at growth hormone disorders. So first, let's talk about the functions of growth hormone. So growth hormone has both growth-promoting actions and anti-insulin-like actions. So growth hormone acts, it's released by the anterior pituitary, and it's going to act on the liver to produce IGF-1. And IGF-1 is going to enhance or increase protein synthesis in bone and cartilage. That's going to lead to increased linear growth. So it accounts for your growth of your long bones. It's going to cause an increase in protein synthesis in body organs. So that's going to lead to increased size and function. And it also acts on the muscles to lead to an increase in lean muscle mass. Okay, let me move that there. It also has anti-insulin actions. So it's going to kind of have opposite effects of insulin. It's going to act on adipose tissue to increase the breakdown of fat and encourage the use of free fatty acids. And this is going to lead to a decrease in adiposity, or decrease in fat. In terms of carbohydrate metabolism, it's going to lead to increased glucose use. Decreased glucose use. And that's going to lead to an increase in blood glucose levels. So it's going to raise blood sugar levels. Okay, so now I'm going to talk about short stature in children. It's not always caused by inadequate secretion of growth hormone. So let's look at some of the many causes. One cause could be chromosomal, as in the case of Turner syndrome. It could be due to protein-calorie malnutrition or malabsorption syndrome, such as celiac disease. Any chronic diseases such as kidney diseases or diabetes mellitus, hypothyroidism, hypercortisolism, and then of course we have inadequate secretion of growth hormone. Inadequate secretion of growth hormone can be due to pituitary tumors, agenesis of pituitary somatotropes. That means a lack of development of the somatotropes, those cell types that secrete growth hormone. So that would be a congenital defect. Inadequate secretion of growth hormone releasing hormone, and that's from the hypothalamus. There's another condition called Laron type dwarfism, and this is a condition due to growth hormone resistance. So rather than a decreased amount of growth hormone. So growth hormone, the tissues, like in the liver, do not produce enough IGF-1 in response to growth hormone. So that's due to abnormality in the growth hormone receptor. Okay, so let's look at growth hormone deficiency, also called dwarfism. So here we have inadequate secretion or response to the growth hormone. Manifestations in children, this is going to result in short stature, but normal intelligence, immature facial features, a delay in skeletal maturation, and this can cause really low blood sugar or hypoglycemia in the neonate. Here's some twins, one with dwarfism and one without. Treatment is going to be with human growth hormone, or in the case of Laron dwarfism, human IGF-1. Ideally, you want to catch this early so that you can treat with these hormones before puberty and the growth plates close. Okay, if we have a growth hormone deficiency acquired in adulthood, this is not going to result in the short stature because the long bone growth has already occurred. So this can result in a decrease in lean body mass and an increase in fat mass and hyperlipidemia, a decrease in bone density, insulin resistance. And this is usually the result of pituitary tumor or the treatment for a pituitary tumor. We can also have growth hormone excess. Gigantism occurs when we have hypersecretion of growth hormone in children and adolescents pre-puberty, before the plates close. And this is going to result in excessive skeletal growth. Here we have the tallest man on record, I believe, at about 8'11", next to his father at 5'11". So he has a gigantism. There we go. We can also have growth hormone excess post-puberty, and then we call it acromegaly. And so here the growth plates have already closed, but it can cause thickening, and this particularly causes thickening of small bones of the hands and feet and skull. It can cause a kind of a protruding jaw, slanting forehead, a deepening of the voice, arthritis due to bone overgrowth, enlarged heart, and hypertension. That can lead to congestive heart failure. It can lead to abnormal blood glucose levels and diabetes mellitus because of its anti-insulin actions. And CNS problems, and this is due to the space-occupying lesion. So if we have this pituitary tumor that's occupying space within the brain, we can have the headaches and the vision problems. This is almost always caused by a benign pituitary tumor and is of slow onset. Okay, let's take a look at thyroid disorders and the thyroid gland. So the thyroid gland is the largest pure endocrine gland, and it's composed of follicles that produce thyroglobulin. In the lumen of the follicle, we have stores of colloid, and colloid is the thyroglobulin plus iodine. And this is going to make the precursor for a thyroid hormone. We also have parafollicular cells that produce the hormone calcitonin, which is involved in regulating blood calcium levels. Okay, how is the control of the thyroid gland? So in response to sleep, cold temperature, or stress, the hypothalamus releases thyroid-releasing hormone. Thyroid-releasing hormone acts on the anterior pituitary to cause the release of thyroid-stimulating hormone. Thyroid-stimulating hormone acts on the thyroid gland to cause the release of thyroid hormone, and these are T3 and T4. T3 is the more active form. T4 gets cleaved to T3 at the tissues. More T4 is released than T3 from the thyroid gland, but T3 is the more active form. So T3 and T4 have their effect on target tissues, and then they also negatively feed back to suppress release of TSH and to suppress the release of thyroid-releasing hormone. Thyroid hormone has a lot of function. Its main function we think of is on the metabolic rate. So it increases the metabolism of all body tissues except for things like the retina, spleen, testes, and lungs. And this is going to lead to increased mobilization and metabolism of glucose, fat, and protein. And this is going to lead to increased heat and energy production. So it's going to increase your basal metabolic rate and increase your body heat. Its effects on cardiorespiratory function is going to increase oxygen consumption and metabolic end products. It's going to cause systemic vasodilation and increase blood flow to the skin, and this will release heat. It's going to cause increased blood volume, increased heart rate, increased contractility of the heart. This is going to lead to increased stroke volume and cardiac output, although the blood pressure is going to remain relatively constant due to that vasodilation in the skin. Gastrointestinal, it's going to increase motility in gastrointestinal secretions. It's going to increase appetite. Neuromuscular, it leads to increased muscle tone. It is also important for normal brain development in the infant, and it also causes an increase in sympathetic tone, and this is permissive with the effect of catecholamines. And a permissive effect is that, so you have catecholamines, epinephrine, and if you also put in thyroid hormone, the effect is more than additive. So, and it does this, thyroid hormone acts to cause the upregulation of epinephrine receptors. So that's going to increase the response to epinephrine. A goiter is an enlargement of the thyroid gland, and this can occur in conditions of low thyroid hormone, normal thyroid hormone, or hyperthyroid states. Goiters may be diffuse. They're just kind of an enlarged, we see it just a kind of enlarged gland, or there can be distinct nodules, as you can see here. Toxic goiter is a goiter that results from hyperactivity of the thyroid gland, and a toxic goiter produces extreme signs of hyperthyroidism. We can also have diffuse non-toxic goiters, and these are usually a result of hypertrophy and hyperplasia due to increased TSH due to hypothyroidism. So we can have a goiter in both hyperthyroidism and hypothyroidism. So hypothyroidism, we have a deficit in the production of T3 and T4 by the thyroid gland. We can have primary hypothyroidism, in which the deficiency is within the thyroid gland itself. This could be congenital. So we have a congenital lack of thyroid gland or abnormal synthesis of T3 and T4. Or it could be acquired. Hashimoto's thyroiditis, this is where we have autoimmune destruction of the thyroid gland, and this is the most common cause of hypothyroidism. It can also be acquired through removal of the thyroid gland or radiation of the thyroid gland, say for cancer. It can be due to iodine deficiency, in which we can cause it an endemic goiter, where like you're from a region where you just don't have enough iodine in the diet. Not so much a problem anymore. But we used to have the goiter belt around the Midwest, and this was due to iodine deficiency. And in this case, these patients would just need to take supplemental iodine to be able to make thyroid hormone. Secondary hypothyroidism is when we have a problem with the anterior pituitary. And so this is going to be caused by inadequate production of TSH. And then if we have tertiary hypothyroidism, then we have inadequate production of TRH from the hypothalamus. Okay, let's look at the manifestations of hypothyroidism. Because thyroid hormone acts on so many target tissues, most body systems are affected. To kind of summarize some of the main effects, we're going to see decreased energy metabolism and heat production, and this can result in cold intolerance, decreased appetite, yet we have weight gain, decreased neurological functioning, decreased heart rate and cardiac output, and a decreased sensitivity to catecholamines. Decreased muscle tone and reflexes, coarse dry skin and hair, constipation due to decreased motility in the GI tract, hypoventilation, and myxedema. And this is a non-pitting edema that we see especially in the face. Congenital hypothyroidism is when a baby is born, they're normal right at birth due to maternal thyroid hormone, but we see prolongation of physiological jaundice and respiratory difficulty and hoarse cry due to enlarged tongue, some feeding difficulties and lack of interest, and choking. Now, cretinism, this is the manifestation of an untreated congenital hypothyroidism. So we have congenital hypothyroidism, but we let it go untreated. And this can result in mental retardation and impaired physical growth. And this is going to occur in an infant when the thyroid tissue is absent, or with hereditary defects in thyroid hormone synthesis. Myxedema coma is a severe case of hypothyroidism, which can be characterized by coma, hypothermia without shivering, hypoventilation, hypotension, hyponatremia, hypoglycemia, and lactic acidosis due to not enough oxygen metabolism. Hyperthyroidism, this is where we have too much thyroid hormone. One cause of this is Graves' disease, and that's the major cause. And this is an autoimmune disease that's caused by abnormal antibodies that act just like TSH. So these autoantibodies stimulate the thyroid gland to produce more thyroid hormone. So it acts just like TSH, but it's not TSH. It's more common in women than men, and it's characterized by a triad with hyperthyroidism, the goiter, and then we see some changes in the eyes. And this is due to connective tissue changes, and this results in kind of a protruding eyeballs that look like the patient is staring. There's a picture of it on the next slide. I'll show you in a second. We can also have multinodular toxic goiter, and this is where we have some changes in the follicular cells causing them to release too much TSH. And so this is where we can see these little nodulars that have grown, kind of look like little tumors, that causes them to release too much TSH. And this sometimes occurs after increased demand, such as with adolescence or pregnancy. Okay, so manifestations of hyperthyroidism. Okay, so manifestations we can see in hyperthyroidism, we can see a goiter, increased metabolic rate, increased oxygen consumption, increased heat production, weight loss, and heat intolerance. And we get this weight loss despite an increase in appetite. We have increased sensitivity to catecholamines, because remember, thyroid hormone causes upregulation of catecholamine receptors. And this can lead to increased cardiac output, tachycardia, and heart palpitations. It can cause anxiety, restlessness, and irritability, tremor and twitching, fine hair, diarrhea due to increased motility in the GI tract. Exophthalmosis, that's the protruding eyeballs here, and this is seen in Graves' disease. Okay, a thyroid storm is where we have a sudden onset of hyperthyroidism. And this can be triggered in when we have excessive stress in patients with undiagnosed or partially treated Graves' disease. This has a high mortality rate, and this can cause a high fever, tachycardia, high output heart failure. I don't know if we talked much about that with heart failure, but that's where the heart is actually producing high cardiac output, but it's failing to meet the metabolic needs of the body because we have this increased hyperthyroidism, increased metabolism due to this hyperthyroidism. It can also cause chest pain and CNS symptoms. Okay, I put this little table together to help you compare hypothyroidism with hyperthyroidism. So remember, with too little thyroid hormone, hypothyroidism, we have a decreased basal metabolic rate, body temperature, and appetite. In hyper, we have an increased metabolic rate, body temperature, appetite, and sensitivity to catecholamines. Hypothyroidism, we see weight gain. Hyper, weight loss. Hypothyroidism, we have cold intolerance. Hyper, we have heat intolerance. Hypothyroidism, we have constipation. Hyperthyroidism, we have diarrhea. Hypothyroidism causes lethargy, fatigue, depression. Hyperthyroidism causes nervousness, anxiety, insomnia. And then some conditions that are associated with hypothyroidism can include cretinism, and this is untreated, congenital hypothyroidism, and that can result in mental retardation and impaired physical growth. Myxedema, that's the non-pitting edema in the face and thickened tongue. You can also have the myxedema coma. Iodine deficiency as a cause of endemic goiter, and Hashimoto's thyroiditis as the main cause of hypothyroidism. And then in hyperthyroidism, we have Graves' disease, and that can cause the exophthalmosis. Okay, that's the protruding eyeballs. It can also be caused by the multinodular goiter, and then also we can have a thyroid storm. That's the severe acute onset of hyperthyroidism. Okay, I have the answers to the questions on this slide, but I want you, before you look at the answers, to try and predict the levels of thyroid hormone, T3, T4, as well as TSH, and say whether you think the TSH is high, low, or normal in the following patients. Now remember the negative feedback loop. So when T3 and T4 are high, say with primary hyperthyroidism, then what would you expect with TSH? You would expect TSH would be low due to that negative feedback. Also remember, primary is due to a deficit or too much hormone from the target organ, in this case the thyroid gland. And with secondary, it would be due to a problem with the anterior pituitary. Okay, and then for this discussion, I want to make sure that you can understand why you would see a goiter in Graves' disease, which is a hyperthyroid condition, and iodine deficiency, which results in a hypothyroid condition. Make sure you can explain both of those. Okay, I'm going to call this part 1 and come back and produce another screencast for the second half of topic 9.